Thank you for the introduction. Lovely gathering, dear guests and distinguished faculty. Actually, what are we talking about? We're talking about heart failure, and this conference is talking about one of the most debilitating diseases with increased mortality around the world. Not only does it increase mortality, it's the most in health expenditure all over the world because of hospitalization and other problems. The mortality rate, if left untreated or not treated to the best of interest, is very high, and this is why we're talking about this. Not only that, in several studies, the cost of hospitalization is one of the biggest burdens of any health provider in the world. Every single hospitalization increases mortality. If it's the first, second, third, or fourth, the mortality increases, survival goes down. So this is why we're talking about medications, and this is why we're talking about an important topic, which is heart failure. Look at heart failure. What is the most important cause, or the commonest, let's say the commonest cause of heart failure? It's always there as ischemic heart disease. In the Framingham study, it was myocardial infarction, actually. And in more recent data, it's still coronary artery disease in the myocardial infarction case, or even in the chronic ischemic case. So ischemic heart disease, again, an important part. And this is what we're talking about. We know there's a response with a decrease in output with a stimulation of the sympathetic nervous system and the renin-angiotensin-aldosterone system. And this causes faster and stronger contraction, vasoconstriction, fluid retention, and we have to antagonize these. And this is what ACE inhibitors do. They antagonize this excessive renin-angiotensin-aldosterone system activation, sympathetic nervous system activation. They decrease the preload and afterload, improving output, dampen the sympathetic response, this is really important again, and reduce vasoconstriction. And on the long run, they reduce the ventricular remodeling through limiting cardiac hypertrophy, myocardial fibrosis, and even apoptosis. They are not just symptomatic medications, they are mortality benefit medications. And they are still, till now, the cornerstone of heart failure with reduced ejection fraction. Why is that? We know the ARBs are very potent medications with the least side effects of any antihypertensive. They act on AT1 receptors and they decrease the effect of angiotensin II. But if you add an extra benefit with increase in bradykinin, the thing that we think about of bradykinin is the increase in cough. But in fact, bradykinin has an improvement in dilatation, decreases apoptosis, and increases pro-growth and improves mortality and benefits the patients. So don't think of bradykinin as a bad thing. Usually it's a very good thing too. What is the evidence? And this is what we're talking about. 20 years ago, we're just talking about evidence and evidence. We can give a lot of theories, but evidence here really counts. It started up with the enalapril in the consensus with a decrease in cardiac death, worsening of heart failure, and total mortality. And it also in the SOLVE trial, also with enalapril, the total deaths, hospitalizations for congestive heart failure, and worsening of heart failure, and also cardiovascular death were significantly reduced. These are not just the only studies. They showed, were the first studies to show a decrease in mortality in severe heart failure as seen in the consensus, and even in less severe heart failure as seen in the SOLVE trial. And there were more and more studies. There was even a 10-year follow-up of the consensus. And the mortality shown here was even higher with those not taking ACE inhibitors. There was the SOLVE, there was the ATLAS, there was the SAVE, even post-MI, the AIR and TRACE. If you look, a lot was also invested in looking into post-MI heart failure, as in the SAVE, AIR and TRACE. Why? Because as we said in the beginning, myocardial infarction and chronic ischemic heart disease are the #1 cause of heart failure with reduced ejection fraction worldwide. Probably is the #1 also of preserved. And here we can see with captopril, ramipril, and trandolapril, there was a significant reduction of all-cause mortality, up to 27% seen with ramipril in the AIR study. And that is why, when you look at indications of certain medications like the ACE or the ARBs, or the MRAs, you see the ACE inhibitors really, and the ARBs following them, have the most indications, whether it's stable coronary artery disease high-risk patients, acute post-myocardial infarction, reduced ejection fraction, there is a question mark still on preserved and mid-range. But if you look at the meta-analysis, and this was recently published, the benefit of our ACE is that the higher quality of evidence in heart failure worsening over the ARBs. Probably they're nearly the same in most things, but here there is a more potent effect of the ACE. And this is why heart failure guidelines, whether the American or the European, state you give an ACE, not an ARB, not a RAS inhibitor, an ACE inhibitor as a first. And if you look on the far right, it's captopril, enalapril, lisinopril, ramipril, trandolapril. There it goes. Not any ACE has its evidence as seen. Maybe the American guidelines differ. No, ARBs are given in heart failure with a reduced ejection fraction only in intolerant patients on ACE inhibitors. This is another part where ACE inhibitors do benefit patients more than ARBs. So what is the evidence of ramipril in heart failure? Is it in reduction of mortality, reduction of hospitalization, or even prevention? And this is one of the most important studies for cardiovascular outcomes ever, which was the HOPE. And this was published in the New England Journal of Medicine nearly 20 years ago. And it was the effect of ramipril up titrating this drug, a very potent antihypertensive, up to 10 milligrams, always going up with higher doses, which is really important. Not conducted on Western countries only, but in Europe too. And it had an outcome, the primary outcome was that of myocardial infarction, stroke, and cardiovascular death. Taking into consideration these very high-risk patients, an average of 66, highly prevalent coronary artery disease or peripheral vascular disease, and an incidence of diabetes more than the usual. We're talking about the 38, not the 27 or the 25 that we see in most trials. Hypertension was around 50%. These were not hypertension studies, cardiovascular protection studies. And look at the outcomes. Reduction of the composite of cardiovascular death, stroke, and myocardial infarction was 22%, more than a fifth as compared to placebo. Fatal and non-fatal MI, a fifth of patients received, all significantly increased. But look at the development of heart failure. And if you look at the curves are still diverging. They're not static. They're not the same relative risk reduction over the period of time. It's increasing over time. There is a 23% reduction of development of heart failure with ramipril. Unexpected death, fatal arrhythmias, resuscitated cardiac arrest also was significantly decreased. And this was a cornerstone showing an ACE inhibitor, ramipril, in the dose of 10 milligrams, reducing the risk of cardiovascular events and heart failure by 23%. So this is really important. We're not just reducing cardiovascular events, we're reducing also heart failure. And this is why a lot of us are thinking of what is the pathophysiology of coronary artery disease and heart failure. And this publication by one of our colleagues, Islamic Gindi from Florida, he was talking about so many things that are really seen. And even newer data on heart failure with this drug has been shown. And this is why in the chronic coronary syndrome guidelines that were published last August, ACE inhibitors in chronic coronary syndromes should be considered in ischemic heart disease patients at high risk of cardiovascular events. It's a prevention of cardiovascular events. ACE inhibitors, you can see it, it's just written there. And if you have also, you can give an ARB in certain cases to reduce heart failure, hypertension, or diabetes. So this is why ACE inhibitors are extremely important, and the evidence was thanks to the HOPE trial. How about in heart failure, this established disease? Yes, there is data that it shows improvement in NIHA classification, and NIHA classification provides a mortality benefit better than a lot of other surrogate markers. The improvement in the NIHA classification is what reduced mortality even in sacubitril valsartan. So here we have data years and years before the advent of other medications that ramipril improves the NIHA classification. Not only that, we were talking about hospitalization as the biggest burden for patients and for healthcare providers. Again, a 32 reduction in mortality and hospitalization, a third of patients, a lot, which is slightly significant. And there is also the AIR study. It was comparing ramipril with up titration to 10 milligrams again versus placebo on patients to see the clinical evidence of any heart failure after an acute myocardial infarction, the commonest cause of heart failure. Look at what they're thinking about, yes. And what did it show? Definitely, survival was better with ramipril and reduction in mortality was seen so significant. And there was even a longer duration of follow-up in the AIR-X, and there was even a better improvement of patients with a number needed to treat very, very low and relative risk in mortality up to 36%. Okay, as you can see, it's diverging. It's not static, it's not plateauing, it's diverging. There is an improvement with this ACE inhibitor, ramipril, on reduction of mortality and cardiovascular events. I came through a lot of data on ACE inhibitors, which one is better, which one is best. I think most of them are equal, but this article was published last year, and it showed, if you look overall, ramipril was better than enalapril and lisinopril significantly for hospital outpatient patients with heart failure as reduction in mortality, or if you want to say it in the other way around, patient survival. But if you adjust them to doses, all ACEs are really near equal. But if you take the whole population, those on ramipril were doing a little bit better. And this is why ACE inhibitors are indicated in hypertension. And if you have hypertension with nephropathy or albuminuria, they're indicated on top of ARBs. Heart failure with reduced ejection fraction, you saw the guidelines, whether American or European, it's an ACE inhibitor. Acute myocardial infarction, you saw even with chronic stable angina. For prevention, it's an ACE. It's thanks to the HOPE. And I think also it was the Europa by Perindopril. And this is why you look, when we're talking about protection, and you talk to cardiologists, you say there are 10 ACEs, there are 7 or 8 ARBs. Why are you sticking with 2 here, 1 there, or 2 there? Because we usually write the ones that protect everything. Here you can see total mortality, cardiovascular mortality, fatal or non-fatal MI and stroke. You can see ramipril is always showing up. And again, I have to say that one of the most important analyses that show that ACE inhibitors are very potent is the HOPE, and you can see it on the top of the chart there. The HOPE study really did a lot for cardiovascular mortality and heart failure. And this is why not every drug is indicated in every single situation. Here, if you look at the Fda Indications, the only ACE is indicated in hypertension, heart failure, congestive heart failure, left ventricular dysfunction, or prevention of myocardial infarction is ramipril. And that's why when sacubitril valsartan is trying to do a study on post-MI patients with reduced ejection fraction, they're trying to compare themselves to ramipril. And this is the Paradise AMI, which is ongoing, and we'll see the data when it comes up. So I hope I'm sticking to time. I think I am. We're discussing the most significantly debilitating disease and costly to health providers. There are a lot of factors that are intermingling in this disease. ACE inhibitors are the most potent. ACE inhibitors by the American and European guidelines are indicated first, whether it's cardiovascular protection before the heart failure, or even in heart failure with reduced ejection fraction. They're number one. You give an ARB or the indicated ARBs when ACE intolerant. The evidence shows us, we've seen a lot of evidence right now, why ramipril is not just an antihypertensive medication. It's a protective drug. It shows efficacy in heart failure with reduced ejection fraction and prevention of heart failure. And that's why in its class, I think it's probably the best. Thank you.